Welcome everyone to another offering of the Canadian Sleep Research Consortium. Today we'll hear from Dr. Alex Sweetman, who's joining us from South Australia, where it's early Tuesday morning. Alex will be sharing with us his experience with CBT-I mapping and implementation in Australia. I'm David Gardner, and I'm on Canada's East Coast at Dalhousie University, which operates in the unceded territories of the Mi'kmaq, Wolastoqey, and Passamaquoddy peoples. These sovereign nations hold inherent rights as the original peoples in these lands, and we each carry collective obligations under the Peace and Friendship Treaties. Section 35 of the Constitution Act of 1982 recognizes and affirms Aboriginal and treaty rights in Canada. So to all of you joining us from across Turtle Island, I'd like to remind you that today's webinar is being recorded and that we'll have a question and answer period at the end. You can add your questions anytime as we go through in the chat, and there'll be opportunity if you want to ask your question in person, so to speak. You can put your hand up and we'll let you respond and interact that way. So let me tell you a little bit about Dr. Sweetman. So Alex is a senior program manager with the Australasian Sleep Association and is on faculty at Flinders University in Adelaide. He's interested in insomnia and improving the management of sleep disorders across the healthcare system. He's chair of the Australasian Sleep Association's Psychologist Education Committee and has led several CBT-I translation activities over the last 6 years. In his short career, he's already made a lasting impact, coining the term COMISA during his PhD training, and I became aware of Dr. Sweetman's work in the past few years when I came across his paper in Sleep Medicine Reviews on the effect of CBT-I on sedative hypnotic use, in which he proposed the dual step care model of CBT-I use and sedative deprescribing. I'll quickly mention to you all in attendance today that Alex has included a unique interactive task for all of us to participate in, and you'll see it relatively early in his presentation. So thank you, Alex, for joining us today, and I'll hand it over to you.
Well, thank you so much, David, for the introduction, and thank you for the invitation to be here to present. It's an honor to present on this work. I feel like I've been really lucky to work with some excellent people on CBT-I translation in Australia over the last 6 years, so it's a really nice opportunity to be sharing some of the work that we've been doing. We're not by any means complete, or we're not there yet, but we've progressed a little way down the line, and I hope that sharing some of our experiences will be helpful for other health networks and countries as well. Alrighty, so I will just share my slides. And you should have my full screen there. Yeah. So as David said, I'm a senior program manager with the Australasian Sleep Association, and I have academic status at Flinders University, Bond University, and the University of Western Australia. The Australasian Sleep Association, or ASA, is the peak professional sleep health and sleep medicine advocacy and education organisation in Australia and New Zealand. We're a small number of staff, about 6 staff. However, we have around 1,000 members throughout Australia and New Zealand. So lots of sleep clinicians, sleep researchers, sleep technologists with interests in a really diverse range of topics related to sleep health, sleep disorders, and you'll hear about today both insomnia and CBT-I as well. Before I begin, I would also like to acknowledge the traditional owners of the lands that I'm joining from, the Aboriginal and Torres Strait Islander peoples, past, present, and emerging. If you follow the dotted line here, this is where I'm joining from, border of the lands of Kaurna and Paramount people. And the Australasian Sleep Association also recognises and pays respect to the traditional owners of the lands where we live and work, both the Aboriginal and Torres Strait Islander peoples of Australia, and the Maori as the Tangata Whenua people of the land of Aotearoa. So firstly, some imposter syndrome here, and why you definitely shouldn't listen to me, and I don't feel skilled or experienced enough to present on this work. I'm really passionate about CBT-I implementation and insomnia and the effectiveness in studying CBT-I, but I have no background at all in implementation science, public health, or government advocacy work. So I have little experience in the underlying theory of this work. I just have a lot of passion for the content. So if you do engage in similar translation activities in the Canadian health context, it would be fantastic for you to also engage in local experts in implementation science, public health, and so on. As I said, we've been going for around 6 years with this, the specific projects that I'll talk about, but all of these activities and programs are still ongoing as well. And we haven't been able to demonstrate a substantial change in access to CBT-I throughout the country yet. So we can't plant a flag in the sand and call our program a success. And finally, I feel like I've been really, really lucky to work with some fantastic people in this area. I've been able to do a lot of the groundwork and a lot of the day-to-day footwork, pulling different projects together and running, coordinating different activities. But some of the small successes and achievements of the program are also because I've had the opportunity to work with hundreds and hundreds of really passionate and experienced people in this area. But considering all of this, I hope that sharing some of the experiences of the barriers, pitfalls, and small achievements that we've experienced along the way will be helpful in informing CBT-I implementation in Canada and other locations. These are some of the brilliant people that I have had the opportunity to work with. So for 3 years, from 2019 to 22, I was at Flinders University as a postdoctoral researcher, working really closely with Leon Lack and Doug McAvoy on a National Centre for Sleep Health Services research, funded by the Australian Government and National Health and Medical Research Council grant. As part of that national centre, Sally Redmond, CEO of the Sachs Institute, Doug and I co-led a knowledge translation or CBT-I implementation program that I'll talk about. Sally is the expert in knowledge translation. So Sally is the immediate ex-CEO of the Sachs Institute, a knowledge translation centre in Sydney, Australia. So Sally really led Doug and I to commence with a lot of these activities. And then around 2022, the Australasian Sleep Association won a separate Australian government grant from the Department of Health and Aged Care. And for the last 3 years or so, I've been working with the Australasian Sleep Association as a senior program manager to lead this grant, working really closely with Marcia Balzer, CEO of the Australasian Sleep Association, as well as a friend and colleague, Stacey Putland, who's a pharmacist leading a separate grant providing insomnia education and doing implementation work with pharmacists. So this gives you an idea of the different organisations involved in this translation work, the different grants that have funded this work. But the theme throughout the whole time here has been trying to improve the management of insomnia and specifically access and use of CBT-I throughout the health system. And in addition to these people, again, hundreds of collaborators, and I'll try and show lots of images on the screen for people that have been involved in a lot of these different activities throughout the presentation. If you know the landscape of CBT-I well, you can switch your brain off for the next 30 seconds, because I think this is quite similar across both countries. So I'll fly through this. An estimated 15% of 26 million Australians have chronic insomnia disorder, and CBT-I is recommended as the first-line treatment in pretty much all major Australian and international sleep, primary care, and medical guidelines focusing on insomnia, including this guideline here from the Royal Australian College of General Practitioners in Australia. And as you know, this is because there's now hundreds of clinical trials and over 40 meta-analyses demonstrating that CBT-I is an effective and durable treatment for insomnia, including when delivered over different modalities and delivery formats to different samples and specific samples of patients and across different health settings. Despite all of this evidence and the strong recommendations, though, CBT-I is only accessed by about 1% of people with insomnia in Australia. So this graph at the bottom is showing the way that insomnia is managed in primary care settings in Australia. And this was documented over a 15-year period from 2000 to 2015. It was found that of patients with primary insomnia presenting in general practice, about 90% of the time it resulted in a prescription for a sedative hypnotic medicine, and that rate was stable over the years. about 20% of the time it resulted in counselling advice. We think probably sleep hygiene recommendations or relaxation recommendations, and only about 1% of the time were patients referred to a specialist, likely a CBT-I practitioner or sleep psychologist here. So it's been stable over time. And Dr. Jenny Haycock at Flinders University has updated this literature in different ways, and that rate is still stable at about 1% of people with insomnia actually accessing CBT-I. So it's important to think about why this is. Why is there this huge gap between evidence-based guidelines and what happens in practice? And how can we reduce this gap? How can we improve access to CBT-I? It's also important to note that we are standing on the shoulders of giants here. So the components that now make up multi-component CBT-I have been around for many, many decades, in addition to multi-component CBT-I, or what we now know as cognitive behavior therapy for insomnia. Two graphs on the bottom also show increasing research attention over time. So on the left, we have data from a systematic review and meta-analysis of randomized control trials looking at pharmacological and non-pharmacological interventions for insomnia. And we can see this increasing trajectory of clinical trials over time. And then on the right, we can see my quick and nasty search of PubMed for any articles, including the word CBT or the phrase CBT-I in the abstract or title. And again, we can see this increasing number of articles over time. Almost 200 articles published in 2023, including CBT-I somewhere in the abstract or title. So a lot more research attention, and hopefully we'll see this translate to improved access to CBT-I in the health system and community over the next few years. So the National Centre for Sleep Health Services Research also had a focus on primary care. This is because many people with insomnia are initially managed and seek help in primary care settings. General practitioners, family physicians, GPs are the main point of referral to specialist clinicians in the Australian health system. Many medicines for insomnia are prescribed in general practice, and there's potential to provide further training and education to many thousands of primary care clinicians. So training to GPs, psychologists, nurses, pharmacists, and so on. Pardon me. We also wanted to start increasing access and availability of CBT-I before we embarked on a large public messaging campaign to tell the public about what CBT-I is and where or how to access it and how to demand it. We felt that if we started with the public messaging campaign and drove an increased demand for CBT-I without making it available, that this would be potentially irresponsible if we started guiding clinicians and people to identify thousands and thousands of more cases of insomnia before making CBT-I available. So of course we need to lift both camps at the same time, but we wanted to focus mainly on improving CBT-I access in the community before a large public messaging campaign. So broadly, we started with a general aim to increase access to CBT-I, especially in Australian primary care. So David mentioned that we'll try an interactive exercise now. So this is something that we did ourselves quite early in our own implementation program. It was guided by Sally's team and the Sachs Institute. And this was to develop a visual stakeholder map. So some of you will have come across a stakeholder map before, but if you haven't, it's a tool that organises potential stakeholders by their level of interest in a topic and also their level of interest in a topic or a project. And it helps us to identify potential stakeholders and guide some of the engagement strategies with those stakeholders. So who are the stakeholders? This refers to any organisations that impact the aims and objectives that we're trying to achieve, as well as any organisations that are impacted by our aims and objectives. And for this activity, we're thinking more about organisations, societies, departments, and groups of people instead of individual people. So rather than naming individual clinicians or so on, we're thinking about organisations and societies. So this is the physical map that we'll use in a moment. So we can see on the horizontal axis, we have a stakeholder or organisation's level of interest in improving access to CBT-I from low interest on the left side to high interest on the right side. And then on the vertical axis, we have their level of influence, control, or power over an objective, high influence at the top and low influence at the bottom. So to give you an idea, this is an example. This isn't the exact stakeholder map, but it's an example of what we developed in the Australian context. So the objective and the aim here, stakeholders involved in increasing access and use of CBT-I in Australia. And to orient you to some of the potential stakeholders, groups like the Australian Government Department of Health that have really high levels of influence over this area, but potentially lower levels of interest. The professional sleep organisations, the Australasian Sleep Association, which is the education advocacy body professional organisation, as well as the Sleep Health Foundation, which is more the patient or consumer facing organisation. Reasonably high levels of influence, but much higher levels of interest compared to the Department of Health. Some of the different primary care organisations for GPs, psychologists, nurses, sleep physicians, pharmacists, and so on. So varied levels of influence and interest. Our patient consumer groups relevant to insomnia, as well as university research groups or sleep industry groups with a specific interest in insomnia, really high levels of interest. And then down here we have some of the individuals, so individual researchers, clinicians, people with insomnia, and so on, that probably have extremely high levels of interest, but as an isolated individual, probably lower levels of influence compared to the groups that they represent. So this is an example with the Australian health context and system. I'm completely naive to the Canadian health context and system. So David has very kindly agreed to step in and help guide this activity with a knowledge of the local landscape. But we thought it would be good to try an interactive activity for 2 or 3 minutes. So you can start thinking about this stakeholder mapping tool in the local health context. So why are we doing this? To help you start thinking about the potential stakeholders that might be involved in CBT-I translation, to become familiar with these stakeholder mapping tools, and probably mostly because we were feeling brave enough back in late 2024 to try this out, and now the day has arrived. So in a moment, David will share his screen, and this interactive stakeholder map will be available within the Zoom call, so you don't need to go off to any other websites or anything. On David's screen, you will be able to interact with the different buttons, the widgets, so you'll be able to add text, add boxes, and whatnot from his screen. You'll be able to see some of the Canadian health organisations or relevant departments and societies listed to the side. And we'll ask you to add text boxes on the stakeholder map to represent where these different organisations might fall based on their potential level of interest and influence. And David will show you how to do this in a second. This might look very, very messy, but let's try it out and see how we go. Alrighty, so I'll stop sharing and hand over to you to share, David.
All right. Couple of clicks and we should be underway. Let me know if you can see that.
That's come up for me. Yeah.
Okay. So as Alex has said, there's some instructions here. And if you look at the top left of your screen, we're asking you to click T, and it comes up on my left, there's a little toolbar that has different icons, and when I hover over the T, the text pops up, and then I click on that, and then I can move over and I can add, and in this case, why don't I add PHM for pharmacists and see how that goes. And everybody should be able to see that. So
yeah, that's come up. Yeah.
all right. So people can maybe look through the stakeholders that we've identified. And as Alex was saying, you can pick whichever stakeholder you would like. You can actually add several stakeholders and where you think they actually fit. They may resonate with you, or they may be something that you're just guessing what their level of influence as well as their level of interest would be. So please feel free to go ahead and place your stakeholders.
And there may be others that we haven't identified, so feel free to add additional stakeholders as well. and likely that there'll be some duplication. Don't worry if there's stakeholders are named twice. It's good. It seems to be working for most people, or a lot of people here.
Yeah. Thanks for adding senators. I appreciate that. That's great. Well, we're getting a lot of interest and we're getting a mix of influence.
So this was really handy for us at the start of the program, just to think broadly and identify lots and lots of potential organisations and groups that might be involved in the translation of CBT-I. It's also something that can be repeated over time to see if those groups change, if new groups emerge, or once you start on these sorts of activities, you just naturally become aware of other organisations and groups that can be added as well.
There's a few more coming in. So we have the sleep device industry on the top left quadrant. Provincial governments, Canadian governments also filling that one out. Family physicians, road safety, government services and institutions. Not too many in the low influence, low interest. I guess that's a good thing, other than CA. And CA was, oh, did I do that? Let me see if I can bring that back up.
Insurance, yeah, good one.
Okay.
We spoke about organisations specialising in depression as well. So different research institutes as well as advocacy groups focused on mental health, mainly depression, anxiety, but sleep is obviously extremely relevant. So we've made contact with a few different depression mental health organisations in Australia over the last few years as well.
I see we have a CPA in the bottom left, and we have two CPAs. We have the Canadian Psychiatric Association and the Canadian Psychological Association. If you want to put some differentiating, I'm going to default to that being psychological, but if you want to go back in and change that to clarify if it's psychiatric, but I'll just go with that being psychological. And then I see on the left, at the bottom left, psychologists, a couple of psychologists, bottom right, I should say, not left, bottom right quadrant. So some different opinions, which is important to see. It's interesting, the Canadian Cancer Society having high influence and high interest in the treatment of insomnia. And the Canadian Mental Health Association as well.
It's excellent. Thank you so much, everyone, for participating and engaging in this one straight away. We didn't quite know how this would go, but obviously we've got the right number and the right people on the Zoom call here to make this work.
Yeah. Thank you. I'll close up.
So I guess the webinar's being recorded, so you can go back and look at the lists to revise or add to it. Otherwise, maybe David's happy to take a screenshot at some point in the future and share it if anyone gets in contact with an interest. Or it's a fairly simple exercise. We populated that in the course of about 4 minutes, so you know exactly how it works at this stage. So that was very helpful because I'm completely naive to the Canadian health system and the different organisations and players involved. back to the Australian context. So from the Australian stakeholder map, we started to think about and form a stakeholder advisory group, again, guided by the Sachs Institute and Sally Redman here. And there were several main groups of stakeholders in Australia that we identified. People representing consumer groups, so people with lived experience of insomnia, our professional sleep societies, and also the professional societies for general practitioners, psychologists, the Department of Health and Aged Care, so the government department, and representatives of different sleep and research organisations. So this is where we started with the stakeholder advisory group, but that didn't mean it was fixed. It could grow and shrink over time as well. And throughout this first 3-year implementation project, we met 4 times to collectively agree on the aims of this translation work, to share what everyone was doing and what we're up to, update on progress as the project progressed, and guide some of our strategies. And then in addition to these larger meetings, we had many, many meetings, sort of breakout meetings or one-on-one meetings to clarify different parts of the process. So this is some of the organisations that were involved in the stakeholder advisory group in Australia. So the Sachs Institute and National Centre for Sleep Health Services research here. These are our 2 professional sleep organisations, the Department of Aged Care, as well as one state-based health, people representing one state-based health area, a general practice clinic, a primary healthcare network, professional organisations for general practitioners, rural and remote general practitioners, and the Australian Psychological Society. And these are different universities or research groups with an interest in insomnia and CBT-I. So quite a large stakeholder advisory group. I'll present some of the implementation activities as though they occurred like this, but it was much more like the paper plane at the bottom here. Not always linear, a lot of dead ends. So for every activity that I present over the next 25 minutes or so, there were probably 5 additional activities that we thought about or started progressing that resulted in a dead end. And quite a few times, a lot of revisions, iterative thought sort of thinking. So we got into loops before we found a path forward. All right. So early in the implementation work, it was important to survey the landscape of insomnia management and access to CBT-I in Australia. So this involved a lot of reviews of existing literature, both population-based surveys, so assessing the prevalence, health consequences and current management approaches for insomnia in Australia, as well as a lot of qualitative research with patients that had been published previously. And Janet, based at the University of Sydney, had published a treasure trove of different articles, qualitative articles, working with patients on their experiences. Pardon me. We also undertook several literature reviews, so a lit review on brief behavioural therapy for insomnia that we thought might be feasible for delivery in general practice settings by GPs or nurses. The effect of CBT-I on reducing sleeping pill use, the review that David mentioned at the start of the call. A review on insomnia comorbid with depression and how it's currently managed, and an economic evaluation of CBT-I, a systematic review with meta-analysis down here. In addition to these literature reviews, we had a fantastic group of qualitative researchers that also conducted interviews with GPs, psychologists, nurses, and pharmacists about the current management of insomnia in different primary care settings in Australia, to identify and map what the barriers to insomnia management are, and identify some of the paths forward or different strategies to overcome some of these barriers. So I used to think that some qualitative methods were a little bit of a dark art, but after being adjunct and associated with some of these studies, I think they're worth their weight in gold. They teach us things that quantitative research methods can't teach us, and it's really important to have both sets of methodologies operating in tandem and informing one another. And I'll pepper some of the findings of this qualitative research throughout the presentation as well, so you can see how they directly informed some of the translation activities. So with all of this sort of information mapping the landscape of insomnia, the Sachs Institute guided us to develop this 2-page sort of high-level case for change document that outlines some of the individual and societal consequences of untreated chronic insomnia in Australia, the mainstay approach, which was sedative hypnotic medicine prescribing and use, and also the benefits and evidence supporting cognitive behaviour therapy for insomnia. Concluding in this case for change statement, increasing CBT-I for chronic insomnia and reducing the use of sedative hypnotics will result in significant health and social benefits. So this case for change document was shared with some of the politicians, the people within the Department of Health, as well as some of the partner organisations. And broadly, or I guess collectively, through discussions with the stakeholder advisory group, we planned to try and implement or increase access to CBT-I in 3 main areas. So this was general practitioners and nurses delivering CBT-I, brief CBT-I, or components of CBT-I, looking into evidence-based digital CBT-I programs, and finally promoting access to and providing training to psychologists to specialise in insomnia management and the delivery of CBT-I. So for the rest of the presentation, I'll talk broadly about some of the activities that we've since undertaken to improve or increase access to CBT-I in these 3 main areas. This figure is pretty crowded. It sort of distills some of the main take-homes from our implementation program. The 3 columns represent those 3 areas of translation from the previous slide. So people with insomnia and digital CBT-I, general practitioners and practice nurses, and psychologists. And then working from the top down, it's sort of got some findings from assessing the current landscape, the different organisations involved in the stakeholder committee, some of the barriers that we identified through both our qualitative and quantitative research methodologies, and potential areas for change. So I'll stick on this. I won't read all of this, but I'll let you take a screenshot if you want to draw your attention to some of the main barriers. Insomnia is often not prioritised by people with insomnia or healthcare providers. Healthcare providers receive extremely limited education, postgraduate training, specifically on insomnia and CBT-I. Many general practitioners and general psychologists think that CBT-I and sleep hygiene recommendations are essentially the same thing. Often, insomnia is viewed as a secondary symptom when it co-occurs with other conditions like co-occurring depression and insomnia, pain and insomnia, comesia, and so on. Insomnia is often seen as a secondary symptom, and the downstream effect of that conceptualization is that it might not be important to actually treat the insomnia if it's secondary to something else. Funding pathways are not always clear, and there's very few referral and access options for CBT-I in Australia. That's distilling a lot of information, but hopefully I've given you time to take a screenshot of that one if you wanted to. So I'll talk through these 3 different areas where we tried to implement change in CBT-I, starting with general practitioners. So the Royal Australian College of General Practitioners, RACGP, was one of our main partners in this translation work. Early on, Professor Alan Young, who is the chair of the Australasian Sleep Association's GP Education Committee, invited us to help update some of these online education modules for GPs hosted on the RACGP Learning Centre. So a 1-hour module specifically on insomnia management in general practice that we updated, accessed by about 600 GPs each year. We also prepared many articles on insomnia, CBT-I, comorbid insomnia, and so on, published in general practice journals and magazines. So trying to increase recognition of insomnia, increase recognition of CBT-I, as well as different communication, so brief communication pieces in different primary health network newsletters and communication channels. So this is directly something that stemmed from the qualitative interviews with GPs and psychologists. In Australia, there's already a funding mechanism that allows GPs to refer patients with insomnia to a psychologist that can provide CBT-I. This funding mechanism, it's part of a Medicare set of Medicare item numbers. Medicare is our universal public health system, universal health system. This mental health treatment plan referral item allows a GP to claim a reimbursement for writing a referral to a psychologist, and also allows a patient to claim a reimbursement for part of the cost of sessions with a psychologist. So this mental health treatment plan had already existed for a long time. However, from the qualitative interviews, it became obvious that GPs and psychologists often had a lot of skepticism about whether mental health treatment plans were eligible or could be used for the management of insomnia. Often it was thought that these mental health treatment items were only relevant to conditions like depression, PTSD, bipolar disorder, and so on, rather than the management of insomnia. So we wrote to the Department of Health, who clarified that yes, mental health treatment plans are eligible for referral for insomnia patients. The RACGP helped us subsequently promote this messaging to GPs and psychologists around the country. So actually there is a funding mechanism that exists whereby GPs can refer patients to a psychologist, and that provides a small reimbursement to the GPs, but also covers quite a large portion of the treatment sessions with a psychologist. Through the National Centre for Sleep Health Services Research, Professor Nick Zwar at Bond University also led the development of this brand new online sleep health primary care resource. This is a freely accessible website with a lot of information on both obstructive sleep apnea and insomnia, tailored for general practitioners and primary care settings. Feel free to go and have a look at this resource, and if you hover over these different tabs, you'll see the amount of drop-down information, a lot of information on cognitive behaviour therapy for insomnia, as well as the different components of CBT-I that we know are effective and that we think can be used or delivered in primary care settings. Toward the end of the National Centre for Sleep Health Services research, researchers at Flinders University also led a separate National Health and Medical Research Council grant that was successful. The Management of Sleep Apnea and Insomnia in Primary Care, or MOSSIP trial, is the trial acronym. This is an implementation randomised control trial that aims to embed a fairly comprehensive model of insomnia assessment and management into general practice clinics. So it included a lot of education and training provided to GPs, nurses, and general practice staff, and then different CBT-I access options as well, in addition to a qualitative process evaluation and health economic analyses running in conjunction with this project. And then it wasn't only insomnia, it's also providing all of the tools and education to assess for and manage obstructive sleep apnea as well. So you can imagine quite a complex intervention to try and embed in primary care settings. So now I'll start changing track slightly and start to talk a little bit more about the Australasian Sleep Association grant. So this is spanning from 2022 to mid-2026. This is a Commonwealth grant with a strong focus on primary care, sleep education and implementation, as well as preventive sleep health. To date, around 14,000 general practitioners have accessed evidence-based sleep education through this grant, through different podcasts, webinars, workshops, modules, on-demand resources and articles. It's been amazing to come on and lead some of this work because I've been able to make contact with hundreds of different content experts throughout the Australasian Sleep Association. So lots and lots of different members with specific interests and a passion for these different topics and improving access to CBT-I and other evidence-based diagnostics and treatments for insomnia throughout the primary care ecosystem. So one example of things that we've done, this is a special issue published in the Australian Journal of General Practice in June last year, focusing on sleep health and sleep disorders, including a couple of articles on insomnia management for general practitioners. This special issue was prepared by a team of around 35 sleep clinicians, researchers, and general practitioners. And we did include both GPs and sleep specialists as co-authors on all of these papers. 10 articles, and we think these will be accessed around 30,000 times by GPs and other primary care clinicians. Another example, working closely with Health Ed, an independent GP and primary care education organisation, on a lot of different podcasts and articles for GPs. Again, this was organised partly with help from the GP Education Subcommittee of the ASA, chaired by Associate Professor Alan Young, and around 25 ASA content experts have contributed to these different podcasts, which have collectively been accessed around 8,000 times by registered healthcare providers in Australia and New Zealand. I really enjoyed this one. This was a GP conference in Sydney that we attended last year, hosted by the RACGP, and we had an exhibition stand in the conference centre. This is quite empty at the moment. This was early in the morning that I took this photo when people were still arriving and getting their coffees. We had an exhibition stand, talked to about 500 GPs. There were 4,000 in attendance at this conference. And then toward the end of the conference, we had an insomnia skill building workshop presented to about 150, 200 GPs in the auditorium for this one. And we had fantastic general practitioners. This is Dr. Catherine Andronis and Bianca Cannon, general practitioners presenting on insomnia management and CBT-I delivery, presenting to GPs. So some of the GP champions in insomnia and CBT-I translation work here. So this was amazing to be a part of. So we'll turn our attention to digital CBT-I now. Strong evidence that digital CBT-I is an effective, durable and scalable treatment for insomnia that's effective in the presence of mental health symptoms. In 2021, a group that I lead within the ASA, a psychologist education committee, surveyed the landscape of how many sleep psychologists there were in Australia, and we identified only 65 specialist sleep psychologists in the whole country, which is completely inadequate when we think there's about 3 million people with chronic insomnia. So we think that digital CBT-I options might have a really important place in the landscape of insomnia management in Australia, but it's important to be aware of the potential benefits as well as the limitations, including that digital CBT-I probably isn't appropriate for all patients. Not all patients complete self-guided digital programs, and some people just prefer a human clinician. So we assessed the international landscape of digital CBT-I. Obviously, there's international options with a lot of extensive scientific evidence, but it slowly became obvious that substantial government support would be needed to bring some of these established evidence-based programs to Australia for routine clinical use. So it's possible to bring them to Australia for scientific studies, for clinical trials, randomized control trials, but for more routine, widespread clinical use, it started to become obvious that department or government support would be needed. So we turned our attention to Australian programs. Several programs with emerging evidence. Some were static programs, so one size fits all rather than interactive. Some were single component programs, and there were some programs in Australia that operated as adjunct to CBT-I being provided by a clinician. But we weren't able to identify any programs that provided multi-component CBT-I in an interactive format at that stage. So after 3 years of sort of going in circles and trying to find different programs and assess the landscape, having difficulty increasing the government's appetite for digital CBT-I, we got frustrated and made our own digital CBT-I program. It eventually seemed like the easiest path forward here. So I've worked with Dr. Chelsea Reynolds and Dr. Celia Richardson to develop a prototype of this program. Our wish list on the left-hand side was to develop a multi-component CBT-I program that was highly interactive, could be guided or completed in a self-guided or clinician-guided manner, appropriate for diverse populations, effective in both insomnia and COMESA, something that could be used to support ongoing research studies, and also something that we could get really nerdy with and tweak and change different components or different treatments or the order of components, that sort of thing, something that we could get nerdy with and experiment with in the future. So this is a couple of pilot trials that we ran, small randomized control trials looking at the effectiveness of the program. On the left-hand side, in people with insomnia recruited throughout the community, 50% of these people were using sleeping pills at baseline, and about 80% had a comorbid chronic condition, so fairly diverse sample here. We're trying to break down some of the strict inclusion criteria that have been applied in other previous randomized controlled trials. Large and sustained improvements in symptoms, as we would expect from CBT-I. The second pilot trial in 30 patients with comorbid obstructive sleep apnea, about 90% had tried other treatments for their insomnia in the last 12 months that hadn't worked. And again, large and sustained improvements in these different mental health symptoms, daytime functioning, and almost 90% completed this 5-session program. We've since made it available throughout Australia via a general practice implementation pathway, so providing a referral pathway to GPs so that they can refer patients to access the program for free. Around 350 GPs have signed up to access the program, and about 1,100 patients have been referred across our different studies to date, with reasonably good feedback from GPs and patients. Fairly recently, Nick Swar at Bond University again led an application that was successful with the Medical Research Future Fund to run a 3-arm randomized control trial implementation trial in rural and remote general practice to study this digital CBT-I program, both as a self-guided intervention and in addition to 3 consultations with GPs, so a GP-guided intervention in comparison to digital sleep education control. So that project is just ramping up at the moment. And Celia Richardson, one of the co-developers, has also been awarded a fellowship for the next 5 years to co-design, develop, and test this digital CBT-I program in adolescent populations with insomnia. And finally, some of our work with CBT-I translation with psychologists. So again, not enough psychologists with training in CBT-I. Insomnia often not prioritized, conceptualized as a secondary symptom, and funding pathways are unclear. These were some of the barriers. We've provided training now to around 3,000 registered psychologists. And with Dr. Hayley Meeklem, we've worked together to also run Hayley Meeklem's sleep psychology workshop to an additional 600 postgraduate psychologists in training last year. So a lot of this work has been in collaboration with the Australian Psychological Society, different online articles like this one, CBT-I workshops. So Michael Perlis and Don Posner flew down a couple of years ago and presented 2 workshops on CBT-I in Brisbane and Melbourne, 19 webinars for psychologists with different organisations. These are some of the slides from these psychologist webinars. So a lot of you will be familiar with this, talking about the diagnostic criteria, prevalence of insomnia, homeostatic sleep pressure, the mechanisms of bedtime restriction therapy, and so on, and these 2 workshops with postgraduate students that I mentioned. This is something that was 3 years or so in the making. This is an online 6-hour interactive CBT-I education module that we've developed with the Australian Psychological Society. This was developed with 10 incredible sleep psychologists that I get to work with as part of the Psychologist Education Subcommittee of the ASA. We spent a long time pulling this together because we wanted to pour our hearts into this and make it right. The aim of this education module is that psychologists will be able to complete this, download all of the assessment resources, a manualized CBT-I program, and start delivering CBT-I the very next day in clinical practice. And then psychologists and other clinicians that complete the 6-hour module also have the option to be listed on this CBT-I provider directory that we've developed on our new website, Sleep Central. So Mishka Yates, Communications Officer with the ASA, is leading the development of this one. I think a little over 100 psychologists and other clinicians specialising in insomnia management or with training in CBT-I around the country, around Australia and New Zealand, are listed on this one. we can filter by age group, filter by state territory, and we've added New Zealand as an option here now, just to help GPs identify local psychologists and also identify, or prospective clients to identify local psychologists that have training in CBT-I, that know what CBT-I is, and that they're not just going to receive sleep hygiene information. So over time, we've been able to provide education to a little over 22,000 primary care staff throughout Australia in insomnia, CBT-I, sleep health, and other sleep disorders through these ASA programs. I was thinking of some of the things that I've learned over the last few years and what I would do differently if starting again. So first one was to talk to many, many different stakeholders. So to not be scared of talking to people about insomnia and CBT-I. And for every sort of activity that results in a small achievement or a small win, there's another 4 or 5 that don't eventuate or don't go anywhere. So to not be scared to talk to a lot of different stakeholders. That it's important to have multiple different points of contact within each. People get sick, people go on leave, people get distract radar, so it can help patients. Really helpful to run population-based surveys to benchmark access to CBT-I year by year, both to benchmark what CBT-I access is like at baseline, as well as every 1 to 2, 3 years to work out whether we're improving access to CBT-I over time. So to do this in a really uniform way. Number 4, to identify and support some of the sleep health and insomnia champions of different fields. So the early adopters of CBT-I that are passionate about insomnia. So the GPs, nurses, pharmacists, and so on that will be passionate about sharing knowledge and resources within their field, and also start to build a network of people around them. And finally, we're getting slowly better at this now, but more consumer involvement from the outset. I think we were awkward with this to begin with, but more and more we're developing and working with consumer groups or lived experience groups or panels within lots and lots of different fields of medicine. And this is really important to include the consumer voice in any activities that will impact consumers. We've talked fairly high level about CBT-I implementation and working with lots of different partner organisations. So I wanted to bring it home to an individual person. This is used with consent. A patient with COMESA that completed our program 6 months or so ago. So your program has changed my life. I still have the occasional bad night, usually through waking too early, but I can get myself back on track quickly. I don't stress about it anymore. My life is very different these days. I enjoy being alive and my mental health is better than it's been in a long time. I get up in the morning and I look forward to my day instead of dragging myself out of bed to face another day of angst and exhaustion. So to bring it home to an individual person and why we think it's important to do this sort of work. Obviously, none of this happens alone. I've tried to talk to or to share profiles and names of lots and lots of different people and organisations throughout the presentation, but here are a few of the key players and people again. All of the staff at the Australasian Sleep Association who do amazing things working behind the scenes. Bottom left, some of the sleep psychologists that I get to work with the ASA Psychologist Education Subcommittee. This is a really hard-working and passionate group of psychologists dedicated to improving the management of insomnia and knowledge and access to CBT-I. Sally and Michael and others at the Sachs Institute for guiding the earlier translation work. Chelsea and Celie, who have co-developed this digital CBT-I program and have been working on the different implementation trials. A lot of the researchers at Flinders University and the Mossop team who have led a lot of the work in the earlier National Centre for Sleep Health Services research and also that general practice implementation trial, as well as the Rest Up team. Sorry, Rest Up is the acronym for the General Practice Digital CBT-I implementation trial, and then hundreds and hundreds of content experts within the Australasian Sleep Association, a lot of people that have participated in our clinical trials, and obviously lots of the different partner organisations that we've been able to work with. So I will stop sharing there, and apologies if we've gone over time. But look forward to any questions and discussion.
Thank you so much, Alex. It's really thought-provoking information you've shared, but also at the same time, I think it's really encouraging. It, it you showed that kind of image of the string going all over the place, but yeah, as you said, it kind of feels like so much has been done, so much progress has been made, so much training has gone on from probably next to no training to not just hundreds, but thousands of individuals who would be critical for the implementation of CBT-I across the country. And you started off so humble saying we basically haven't done anything and the needle hasn't moved. It doesn't feel like that when you're on this end watching your presentation. So I suspect the needle has moved more than you're letting on. So please put your hand up if you have questions, and I'll try to watch for that. And I know that Anne and Rebecca will be doing the same. Um, when I think of this, capacity is critically important, and it sounds like you're driven by the thoughts of capacity, so that you've talked about the digital options. And when I think of the CBTI step care model, think of self-care as has the potential for having the biggest capacity for where most people can do things on their own and maybe take care of what really has been chronic insomnia for many years for them. And then there's people who need training and be able to have access to it without barriers, costly barriers in some cases. So my question with all of that is, have you thought about or have you already done a bit of modeling around where the capacity can come from and what capacity is actually needed from the different, and I don't want to call it tiers, but the different access points,
Yeah, yeah, yeah,
CBTI?
yeah. Brilliant question. I really like thinking about the stepped care model and how do you actually adjust that? And is it feasible to embed that and implement that in a health system that's already pretty resource poor or time poor or overburdened? So how do you make that work? So I think even with the thousands of psychologists and other clinicians that we're providing training to, if one day we want to make CBTI accessible to everyone with chronic insomnia, even after we've been training these hundreds or thousands of clinicians, there'll probably never be enough clinicians with specialised training in CBTI delivery to meet the demand of 3 million people in Australia, and then we can extrapolate to numbers in other countries. So I think digital CBTI absolutely has its place in the insomnia management ecosystem, but then working out what that place is and which patients, which demographics, which people it's most suitable for, and how they should go about accessing CBTI is a really interesting question. So whether some programs are promoted direct to consumer with no clinician involvement, they can log on, they can create an account, pay for it, or access it for free without going through their general practitioner or psychologist. And other programs might be placed as a point of referral by a GP or by a psychologist. So playing with those different concepts is interesting. Um, for the general practice implementation trial of bedtime window that I mentioned with the 350 so GPs referring in,
Yeah.
we're operating that as both a research study but also a service just to make CBTI freely available. And then in the background, we're collecting a lot of data to inform the stepped care model with that as well. So and we've got prevalence data to talk about which the number of patients allocated to different tiers of the stepped care model as well now. So for every 100 patients that are referred by a general practitioner to our digital CBTI program, probably about 10% won't actually have insomnia. Either they'll have sub-threshold insomnia, a score of 0 to 8 on the ISI, and they might need more preventive sleep health recommendations or to normalize what different sleep onset latency times are, what WASO times are, normalize brief awakenings, that sort of thing, rather than a full-on CBTI program. or they might have evidence of another clinical sleep disorder, in which we refer back to the GP and ask them to refer to a sleep respiratory physician. It looks like they might have restless leg syndrome or narcolepsy or obstructive sleep apnea rather than insomnia. So that's about 10% of people referred in. Another 10% come through a screening tool that we've developed, and it looks like they have more complex insomnia or comorbidities or different lifestyle factors that indicate they would be more appropriate for immediate referral to a specialist CBT-I provider rather than a digital program. So clinicians can provide treatment in a much more personalised way than a self-guided digital program. So this is people with a history of sleepiness-related motor vehicle accidents, people that operate heavy machinery or drive for work with sustained vigilance and alertness is really, really important. People with comorbid bipolar, schizophrenia, those that are currently pregnant and so on. So people with either safety, alertness type risks, or people with more complex insomnia that we think is more appropriate for care from a sleep specialist CBT-I provider. And then the remainder 80% of people we think are appropriate for digital CBT-I, and we recruit them into this program and provide free access to the program. And then the evidence for that 80% of people is similar to the line graphs that I showed from the 2 pilot studies. So that's sort of how the stepped care model numbers start playing out. And then at the other end, we reassess for insomnia, and maybe 30% or so of people don't respond so well to digital CBT-I and are provided the recommendations to seek care from a specialist clinician at that point. So that is sort of a rambly way of answering your question, but we've got some data now to map against the theoretical stepped care model and how patients might actually flow through that model in real life.
Yeah, 80% is very reassuring, actually. So that's good to know. Rebecca.
I agree. Very impressive presentation. Thanks so much for sharing. And you've got some kind of warm comments and congratulations in the chat as well, Alex. I just a quick question to maybe piggyback on some of the things you were saying. Sorry if I missed that, but do you have the same type of figures for how many, for example, providers that you've trained in CBT-I actually kind of are regularly kind of delivering CBT-I? Like I sometimes hear from people that you train like, large masses of people, but then they go back to their practice and they're just extinguishing fires. And that, I love that you had highlighted the point of, the how they see sleep as a priority versus everything else that's going on. So I'm kind of curious to see if you've got a feeling on the outcomes from that perspective.
Yeah, so we haven't collected great long-term outcome data. Early on in the ASA program, I tried to set up some surveys of people at sort of 6 and 12 months after they'd accessed training. But like you say, people go back to their clinics and they're putting out fires and they're incredibly busy. So we had about a 5% response rate from those surveys. So we can't glean too much information from that. But in terms of the number that have completed that more specialized training, so the 6-hour interactive course, about 460 or 470 psychologists around the country have completed that 6-hour training, a lot of who have opted in to be registered on the CBT-I provider directory. So we think that those are probably the ones that want to build a client base with insomnia and maintain their specialization in CBT-I. And I guess we started with 65 specialist psychologists in the country. So we've a little bit more than doubled that. But yeah, we're still not at the hundreds and hundreds or approaching the thousands of specialist providers. It's an awesome question following those people up over time. I think it would be really interesting to do that with surveys, with reimbursement to encourage people to actually complete the survey, but also use qualitative interviews to follow those clinicians up and ask exactly whether they've actually been enacting the recommendations or directing people to CBT-I rather than sleep hygiene recommendations. Yeah.
Anybody else with a question? maybe I'll take the prerogative to ask one last question before we let you go, Alex. For family physicians who are less familiar or not familiar yet with CBT-I, my impression is if we talk to them about it without saying there's many people who can do well without full meal deal CBT-I, but can just learn, if you learn a couple of these techniques and you're able to adapt to the patient's needs, it really isn't something that you're going to have to change your practice overnight to try to do. Or referring patients to the very difficult to access one-to-one CBT-I. Sometimes they get that kind of impression that, oh, you have to see a therapist. So do you have any final comments on what we can do to help physicians quickly overcome their preconceptions around what CBT-I and the barriers that they quickly put up in place and say, I can't take that on?
Yeah, it's difficult, I guess. Family physicians or GPs are an extremely heterogeneous group. So some will be much more interested in insomnia and mental health presentations, and some won't be interested at all. So we're working with the whole spectrum. We've focused a lot of our energy and efforts in the people that have some level of interest already, so the lower hanging fruit, and trying to foster and develop champions in the field. And then, like you say, rather than delivering full multi-component sort of 8-week CBT-I programs that probably aren't economically feasible for delivery in general practice or family physician contexts, to look at either brief behavioural therapy for insomnia models, distill some of the behavioural components down, or single component stimulus control therapy that might be able to be delivered in a couple of sessions. So working with different ways to fit the evidence-based components and interventions that we have, retrofit that into a very time-limited model with different funding constraints and time limitations and pressures and so on. And then to do that with GPs that probably already have some level of interest in sleep, insomnia, mental health, and so on, of the 30 to 35,000 general practitioners in the country. Yeah.
Well, I appreciated what you've shared with us and all the different experiences that you had, and also the photos. The photos are so telling, you know, like the photo of the general practitioners conference, the 4,000 people at the conference, and we have something here in Canada called FMF, the Family Medicine Forum, and it's the same idea where we really need to have a profile at that conference. We probably need to have a regular profile at that conference to make it to normalize CBT-I as an option and have them build their curiosity over time and not want to be left behind and so forth. So I think we have to close unfortunately, because we're a little bit over time. But again, on behalf of the Sleep Research Consortium, I want to thank you for saying yes to the invitation and planning ahead of time with us and making sure that the technical challenges worked out well. I'm really glad we went for it, and I think it was a big success.
Likewise.
And I really hope that we'll be able to stay connected and continue to collaborate with you through and learn from you, as well as connect on different projects and so forth. So thanks once again.
Thank you again for the invitation, and happy to help with other projects. And thanks also, David, for running that interactive component there. Yeah.
And I guess it's time for us to go home and time for you to get to work.
That's right. My working day is about to start. Alrighty.